All right, welcome everyone. Today we're going to walk through the pharmacology of Parkinson's disease by looking at it through the eyes of a patient named Neil. His case is really going to help us build a practical framework for how we use some of the most important medications you'll see on your neurology rotation. Let's jump in.
But before we get into all the mechanisms and the molecules, I want to start with the human side of things. Neil's own words here. It feels like my body is betraying me. I mean, that just powerfully captures the personal impact of this disease. It's a perspective we absolutely have to keep front and center.
So, this is Neil. He's 68, a retired architect. And his wife, well, she was the first one to notice the little things. Over the past year, he just gotten slower, more stooped. And the real giveaway was that his right hand would start to shake when he was just sitting there watching TV. Now, our first job as clinicians, as you know, is to translate that story into a syndrome. That shaking his wife saw, that's a classic resting tremor. His slowness, the thing that makes just buttoning a shirt feel like climbing a mountain, that's bradykinesia. And for him, that's the most disabling part. And that feeling of stiffness he describes, well, that's rigidity.
Okay, so we have our clinical diagnosis. The next question is, what's happening on a neural level? Let's take a look at the gold standard treatment, which is really all about restoring a critical chemical balance inside the brain.
The whole problem starts deep down in the midbrain. And this slide, it just gives you a stark picture of the progressive loss of these dopamine-producing neurons. They're in a little area called the substantia nigra pars compacta. Now here's the kicker. By the time motor symptoms like Neil's even show up, a staggering 60 to 80% of these neurons are already gone. It's really incredible.
So the logical next step is to replace that lost dopamine. But here's our first big hurdle. You can't just give someone a dopamine pill. It doesn't cross the blood-brain barrier. So instead, we give its precursor, levodopa. But the problem, as this diagram shows so well, is that if you give it by itself, more than 99% of it gets converted to dopamine outside the brain. It just gets chewed up in the rest of the body, causing a ton of side effects like nausea and dizziness, and almost none of it gets to where it needs to go. And this brings us to a really elegant solution. We add carbidopa. I want you to think of carbidopa as levodopa's personal bodyguard. It's a drug that blocks that premature conversion, but, and this is the key part, it doesn't cross the blood-brain barrier itself. So it does its job out in the body, which dramatically cuts down on side effects, and, as you can see, boosts the amount of levodopa that actually reaches the brain to about 10%. This combination is the absolute cornerstone of our treatment.
So we know what our best tool is, but the next big question is when and how do we use it? For a newly diagnosed patient like Neil, this first decision is really important. So let's look at the options for his initial therapy. The American Academy of Neurology guidelines basically frame this first decision as a major trade-off. As this table lays out, levodopa gives you by far the strongest control over motor symptoms, but it comes with a higher long-term risk of causing those involuntary movements we call dyskinesias. The other options, like dopamine agonists and MAOP inhibitors, are less powerful but have a lower initial risk of those motor issues, though the DAs come with their own set of side effects to watch out for, like hallucinations and impulse control problems.
Okay, so how do we apply this to Neil? We have to look at his specific situation. He's 68, right? That actually puts him at a lower risk for dyskinesia, but a higher risk for some of the cognitive side effects from dopamine agonists. His symptoms are already getting in the way of his life. He loves building models, and that takes fine motor control. So given his age and his goals, starting with the most effective drug we have, levodopa, is clearly the recommended path. We'll just start low and go slow.
Now, starting levodopa is just the first step. This is a long-term journey with Neil. We have to be thinking ahead and anticipating the challenges that are gonna come up down the road. Because that initial fantastic response, what we often call the honeymoon period, well, it inevitably starts to fade.
This graph right here is the key to understanding that long-term course. In the beginning, you see that nice, smooth, stable response to the medication. But as the disease gets worse and more of those neurons are lost, the brain just loses its ability to buffer dopamine. So after about 5 to 10 years, that therapeutic window gets narrower and narrower. And that's when you start to see these motor fluctuations pop up.
The very first and most common complication that Neil will probably experience is wearing off. It's exactly what it sounds like. The benefit from each dose of levodopa just doesn't last long enough to get him to the next scheduled dose, and so like clockwork, his Parkinson's symptoms start to come back. And on the flip side of that coin, as his brain becomes more sensitive to the dopamine, he might develop what we call peak dose dyskinesias. These are those really troublesome, involuntary, almost dance-like movements that happen when the medication is at its strongest. Our whole goal becomes trying to find that sweet spot right in between these two states. So when Neil inevitably develops these motor fluctuations, what do we do? How do we adjust his regimen to kind of smooth things out and keep him in that therapeutic window for as long as possible?
Well, for wearing off, our goal is simple. Extend the on time.
We can do that by what we call dose fractionation, basically giving him smaller doses more often. Or we can add another medication. For those troublesome dyskinesias, the strategy is different. We need to reduce that dopaminergic load, often by lowering his individual levodopa doses or by adding a drug like amantadine, which can help calm those movements down.
We've got several classes of adjunct medications in our toolbox to help us out. Things like COMT inhibitors. They work out in the periphery to basically act as extenders for each dose of levodopa. Then you have MAOB inhibitors, which work inside the brain to block the breakdown of dopamine itself. We can even add back those dopamine agonists to provide a longer, smoother kind of stimulation.
And finally, this is absolutely critical. We have to remember that we're not just managing dopamine levels in the brain, we are caring for a whole person. And Parkinson's is so much more than just a movement disorder. A truly holistic plan is paramount. That means we have to proactively manage all the non-motor symptoms, things like constipation, sleep problems, depression, which can honestly be just as bad, if not worse, than the motor symptoms. It also means bringing in physical and occupational therapy, education, and family support right from day one. So what does all this mean for Neil's prognosis? While Parkinson's is progressive, it is so important that we convey a message of hope. With good, optimized management and a strong partnership between us, Neil, and his family, he can absolutely expect to maintain a high quality of life for many, many years. And way down the line, we even have powerful advanced therapies like deep brain stimulation if we need them. Okay, so let's distill this all down. As you're starting your clerkship, what are the core concepts you need to take away from Neil's case? Number 1, this is a clinical diagnosis. Number 2, the core problem is a loss of those dopamine neurons. 3, levodopa-carbidopa is our most effective therapy, thanks to that really elegant mechanism. And finally, number 4, long-term management is all about the challenge of handling those motor fluctuations. So Neil's case really gives us a fantastic framework for understanding not just the what, but the why behind our treatment for Parkinson's, all the way from that first visit to managing things for the long haul. It really is a great example of blending sophisticated pharmacology with personalized, holistic care. With that, I'd be happy to take any questions you have.